Hi, everybody. Dr. Mohammed here. This was the presentation we would have had tomorrow, or we would have had on the 5th of March. My apologies that I won't be able to make the meeting. So I hope you guys would enjoy listening to the explanation. I don't actually like doing them like this. I prefer to have you guys around and involved, but unfortunately, circumstances beyond my control. But I hope that we'll still be able to learn quite a bit. Okay. So this time we had talked about trauma, ophthalmic trauma in the emergency department the last time. So this time we're basically going to talk about non-trauma, non-traumatic emergencies that can present to you in your emergency department. And the majority of our hospitals don't have an ophthalmologist. Or even if they do have an ophthalmologist, there may not be somebody on call, or they may only be available sporadically. And sometimes you have to make rather quick decisions. Or alternatively, you have to transfer the patient to a tertiary center. You have to be able to explain what's going on. You know, once you speak the language of the person that is receiving the patient, they tend to be a lot more receptive, which is something I always say. And if you don't speak their language, it's often quite difficult. So hopefully we'll learn some of the language as time goes on. All right, but let's have a look. So the important thing when you have any of these patients with any sort of ophthalmic problem, you've got to consider their pain. Are their pain levels severe? Are they moderate? Are they low? Because this can actually guide you as to where you're going. Now, majority of us in the emergency department will get patients with relatively high amounts of pain. So a high amount of pain should alert you to the fact that something may be going on. Itching, also another good one to ask about because vernal conjunctivitis, allergic conjunctivitis, these can all cause quite severe itching and what you would call blepharospasm. And pain can also cause blepharospasm. Blepharospasm is just a fancy way of saying that the eyes are shut tight, but that can definitely help. Flashing lights. Flashing lights generally indicate retinal problems. Not always, but generally retinal problems. Retinal detachments, retinal infections, retinal hemorrhages. There's quite a few things that fall under that. So these are the types of things that you ask about. And very often patients will actually give up this information as soon as they come in. They'll start telling you exactly what's wrong with the eye. Changes in the visual fields, so narrowing of the fields, curtains, veils, they can't see out of one side, and you've got to be able to test the visual fields. Now, this presentation that I'm giving you today doesn't have the scope to actually go through a full eye examination per se. And that's something I would suggest that you Google or read about if you want to have a look at how exactly do you examine the entire eye. And, some of them are quite helpful, some of them not so much. Like, for example, they may tell you need a dark room, you may need a lot of things, but we don't necessarily have all of that. But anyway, we'll get into that in a little while. Changes in acuity also very important. I could see well yesterday, doctor, but today it's all blurry and I can't see anything on this edge, for example. So the patient may point to the right edge, if, for example, of the right eye and say, no, I can't see anything out of there. And especially blurriness and all of these things also start getting you worried about what could be happening in the eye. And always remember the eye is intimately connected to the brain. So it doesn't mean that because the symptom is present in the eye, whatever's happening is also in the eye, it may also be in the brain. Contact lens use, very important. Some people are not very good at using their contact lenses. They may cause infections, ulcerations. Previous eye surgeries can also guide you, especially when it comes to things like glaucomas and things like that, or can, recurrence of certain conditions. And then, of course, chronic illnesses such as diabetes, hypertension. So, I mean, it's a basic history. It's just you're going to add on a few things for the patient's eye. I mean, the patients come in specifically for an eye problem. So you need to be able to just pick out a few things from there. It is difficult because if you were like me, we spent 2 weeks in the eye clinic in university, and they basically put us in front of a slit lamp, and we looked at cataracts for 2 weeks, and then we went home. And then they gave us an exam that they basically gave everybody for the last 6 years, or 10 years, or 15 years. They didn't even change the order of the questions. So all of us just learned off the answers and went in and wrote, and we passed. And they said we were competent in ophthalmology. Now, that's where the problem comes about a lot of the time. So the most important thing in your examination is just to be orderly. So generally what you would advise is have a look at the visual field. All right. So the visual field, let me just put this up. Let me just try this here. So So remember, once you're trying to get with the visual field, I just want to show the panel just so that I can talk to you guys a bit better. Okay, let's just increase that a little bit. Sorry, just going to move this a little bit over there. All right, put it to, yeah, just so it doesn't look like I'm looking to my right-hand side all the time. So when you're looking at the visual field, you're basically trying to assess a few things. So you want to test the patient's peripheral vision, then you want to test their central vision, then you want to be able to test again the central and peripheral and things like that, you know. So, you know, we normally ask, now remember, you're not testing eye movement, you're actually testing visual field. So you're trying to see at what point the patient can see your finger. You're trying to assess whether they've got blindness on the inside or the outside, or the top or the bottom. And this is why I say I don't this particular lecture doesn't have the scope to go through it. You know how you check a visual field completely, how you check visual acuity completely. So I would suggest that you guys go and have a look at those. There's some lovely, lovely videos online that show you exactly how it should be done. Your pinhole test, your Snellen charts, how exactly you move your fingers in, how you move them up, how you move them down, and how you check visual fields and things like that. So I would suggest that you guys have a look at that. It's something nice to read about. It's a whole thing on its own. How do you do an eye examination? Just like how you do a neuro examination, even without getting into pathology. How do you just do the examination? So I just wanted to show that. And of course, eye movement. The easiest way to test eye movement is to draw a capital H and get your patient to follow that, and that actually tells you how your eye movement is as well. Then you check the sclera. Okay, then you check the cornea, then you check the pupil. I'm just going to take myself away. All right. Sclera, cornea, pupil, conjunctiva, the adnexa, and then the lids. And then you check ocular pressure as well. Now, ocular pressure can be checked in multiple ways. There's specific tonometers that you get. You can just use your thumbs, essentially. You know, you place your thumbs on either side on each eye, and then you feel it. You know, the higher the intraocular pressure, the more solid the eye feels. And generally, if it's soft and squishy, you should be okay. But remember, we are not working in an eye clinic, in an ophthalmology clinic. We are trying to ascertain in a quick manner what could be wrong with this eye. Does this patient need urgent referral? Does this patient need delayed referral? What exactly is going on? But the most important thing is be orderly. Now, this in itself, this what I'm talking about here is a whole lecture on its own. And hopefully maybe towards the end of the year, once we start running low on topics, maybe I'll spend some time going through that with you guys. Okay. All right. So just to give you an example of your visual field, so how you have a look through, and then we all remember these pathways that confused the heck out of me when I was at university. I tried to learn them, but I was never that good. And eventually, like I say, I just learned of the past questions, and that was about it. So the most important thing is to try and get an idea of where the problem may be. So that's what we're doing by checking visual fields. Because remember, visual fields are not telling you specifically about the eye necessarily. They're talking about this entire pathway and where you may have problems. All right. So it's a nice thing to learn of. If you've got a big brain bigger than mine, hopefully it can even stick in your memory. But for me, this is something, even when I was drawing up this, I sat with this for like half an hour trying to learn it again. And actually, I just gave it up, you know, it's because these days I just refer everything to our ophthalmologist, and like, I don't really need to know it. It's not a good idea, but I would suggest some of you those of you who still have plasticity in your brains because of youth, try and learn this. Okay. But basically, what we're trying to say is that as you like, for example, if you say, like, let's take number one, right, where they show that you've got a complete blindness in the right eye, it's because you've got a whatever it may be that's cutting off the transmission of your optic nerve at this point, right? So if they're saying number two, then it shows you this is at your optic chiasm on the not in either track, because remember the tracks cross over. You know, the what you call it, the medial tracks cross over, the lateral tracks don't cross over. So you know, there's a whole lot of things that you got to learn. That's why I say it's a whole lecture on its own. I don't want to get into it, but any change in the visual field should prompt you to get worried. Okay. Now, this doesn't necessarily mean that you're going to refer the patient only to an ophthalmologist. It may mean that the patient needs a CT scan prior. You've got to take a more detailed history. What could have caused this? Was it due to trauma, non-traumatic? Is there coagulopathies? There's so many things. But, you know, keep this as a reference for yourself, and I'm sure it can help. Eye movements. Oh my word, that looks horrible. I didn't realize it would be that bad. Okay, but anyway, this is just to show your eye movements of each eye. So you, for your right eye, your in your just how all your muscles move. But my God, I didn't realize it would project that badly. But just so that you get an idea of which muscle moves your what you call it, eye, in which direction. Okay. Also, a very interesting little topic if you've got a bit of time just to go and learn about eye movements. But that's not why we're here today, because most of us do know how to do a basic examination and how to look at the eye. So we're more worried about how do we, distinguish certain entities from one another. Now, this is just a little trick that I also learned initially when I started in the emergency department that I didn't know. Sometimes, for example, you've got an eye that's in spasm that you need to open and you need to have a look at. It may be due to trauma, not due to trauma. The problem is that if you're not sure what's going on, the worst thing that you can do is place a lot of pressure on the eye. So just by using a simple paper clip and folding it in this fashion, you can actually create a little eyelid retractor. And without much force and without placing any pressure on the eye itself, you can actually open up an eye and have a good look at it. So this is just a little trick that you can use, and it does work quite well. I've used it on quite a few patients, and it really does help. Sometimes you've just got to hook this end in a little bit more in order to get underneath, or bend it a little bit more at the top there, just depending on the size of the paper clip that you're using. But it actually works quite well on the eyelid. All right, so now we get to something that I always enjoy talking about. That's chemical injuries. Chemical injuries are some of the most severe injuries that you'll see in the acute phase. And it's often a perception of people that acids will actually cause more damage, but in the eye, and if any of you did pay attention in your ophthalmology lectures, alkalis are actually more severe. And alkalis are surprisingly common because alkalis are found in most of our cleaning products at home, in even industrial chemicals, things like that, cleaning and things like that. They're more commonly alkali than acid. Acid itself is not actually that common to come into contact with, but it does happen. But acids, because they are more highly restricted, tend to be used in areas that are more highly controlled. But alkalis you can find anywhere. Take your what you call just simple handy Andy, take a little oven cleaner, take all of those things. They all actually contain alkali more than acid. So the problem with the alkalis, it penetrates very rapidly. The reason for that is it actually starts to, well, as they say over here, it saponifies the cell membranes and intracellular bridges. So basically, it breaks down those cells extremely quickly and causes them to separate from one another. So as they break down and as they separate, that allows the alkali to penetrate even deeper, and it just goes deeper and deeper and deeper and deeper, and eventually you get necrosis of the conjunctival vessels. So it causes this cooked fish eye, and it's a horrible thing to see, and these patients are in extreme pain because this sensation is just getting worse and worse and worse, and it's not fun. Imagine having a piece of sand in your eye, how uncomfortable it is. Now imagine an alkali burning through the cells and going down. Whereas if we look at acids, it tends to be less severe. The acids, as they say here, it denatures the proteins in the corneal stroma. So what happens is those actually form precipitates. All right, so those proteins themselves actually start sitting in the cornea, and they form a physical barrier to the acid, so the acid can't get through and cause more damage. So you tend to find with the acids, you get more of a surface type of damage, whereas with alkali, it goes right through. And as they say, it can penetrate right into the vitreous compartments and can cause severe eye damage. So actually be more worried if you have an alkali, right? And yeah, localized damage is due to coagulation effects that they have, protein precipitations at the epithelium level, but basically it creates its own little barrier. So acids actually can't pass further down. So what do you do in the case of chemical injuries? You irrigate. You irrigate and you irrigate with whatever you have. So what I've done on occasion, especially with the alkali, we just give a little bit of local anesthetic and actually stitch a, what you call it, the end of the IV line just in here and let that fluid just keep on running, 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 running. When that bag is finished, just keep on running, 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 running. You just try and pass as much fluid as possible, especially in the alkalis. In the acids, you still got to flush them out quite a bit, definitely, but not as much as the alkali. Which one do you use? I must be honest, use whatever you have on hand. whatever you have on hand, just make sure that you get that eye irrigated, and that will actually help the chemical injuries settle down. But chemical injuries are one of those injuries that the ophthalmologists really need to be involved with quite quickly. And I always say ophthalmology is a lovely, lovely discipline because you don't get called out that much in the middle of the night. But this is one of those, especially with the alkali injuries, where you may just convince an ophthalmologist to get out of bed or even accept the patient, quite readily. The problem is that there is not much that they can do, especially if it's reached this level. Most of the patients, the eye will be nucleated. However, with acids, if you irrigate, there is still quite a good chance of saving it. Essentially what they do after that is that they look for how far it's gone into the globe with the alkalis, and that determines their management of it as well. But the important thing for you in the emergency department is not to sit and classify it, but just to irrigate it as much as you possibly can. You can use those retractors to open up the eyelid, tape them down so that they keep the eyelids open, and you just keep on flushing and things like that. Right? Keeping an eye open for half an hour and an alkali injury, trust me, you rather prevent the alkali or acid injury. Okay. Right, so let's look at orbital infections. So I wonder if anybody can tell me which is an orbital and which is a periorbital cellulitis. Now, the reason why we're asking that question is because your orbit actually has quite a significant septum that sits just above there, right? And that septum is quite a hard piece of fascia. It's very difficult for bacteria to penetrate, actually. So it's sometimes quite difficult to actually decide which one is periorbital and which one is orbital because they tend to occur around the same areas, right? Now, what we're going to do is let's have a look at what are the differences between these two. Let's just physically look. So in both of them, we can see we've got a redness and swelling of the eyelids, okay? We notice that it's extending from below the eyebrow over the entire upper lid. In this case, we've got it more on the lower lid as well. What we can see in this patient, however, is that we can see a clear sclera. We can see the patient is able to open their eyes. Whereas in this patient, we've got a bit of chemosis or scleral swelling or even conjunctival swelling, whatever you want to call it. And I guess it would be because of the theater cap, I'm guessing you would get this is more likely to be the orbital cellulitis, right? So the orbital cellulitis is an infection now that's passed into the orbit itself, whereas a periorbital or preseptal or cellulitis is still being held back by that fascia. But in the emergency department, it can be quite difficult sometimes to differentiate between the two. So let's have a look at the differences. Okay. So with orbital cellulitis, the patients tend to be more toxic. Now, it must be understood this is more common in children, but it can happen in adults, all right? So what do we mean by toxic? We mean this patient is pyrexial, this patient has signs of shock, this patient is lethargic, this patient is ill, this patient is extremely ill. And generally in preorbital or, preceptal or periorbital, patients less toxic, can still be sick, can still be pyrexial, but generally they're still walking, talking, they're okay, they can converse with you, they can respond to you, they can do everything. The orbital cellulitis, this is probably the most important differentiating factor, pain on eye movement. And with the preceptor, you have painless eye movement because in all honesty, it hasn't gone into that orbit itself. It's not affecting the musculature, it's not affecting the soft tissue, it's not affecting the adipose layer, nothing. Whereas in this one, it is, okay? The other important thing, visual acuity is decreased, whereas in preceptal visual acuity is maintained. It's an important difference. Now, visual acuity is not always that easy to elicit in an orbital cellulitis because of how much of pain the patient may be in. But if you can, do it in a preceptor and you'll notice that they can still see quite well and it will start giving you an idea that it's preceptor. The pupils may not react correctly to light. Now, when we say that, it means that they won't necessarily constrict. All right. This depends on the extent of the orbital cellulitis and the what you call it, the segments to which it has gone. Whereas with preceptal, you notice the pupillary reactions are maintained, so they're quite normal. So with the majority of our patients that come, they tend to be preceptal. So you can see by having these negative findings, you can actually exclude orbital cellulitis. With orbital cellulitis, you tend to have chemosis, which we saw on the last patient. So that's chemosis that you see over there, all right? And you notice in this one here, there's no chemosis. So that's another important differentiation, but it doesn't happen on every patient. And in preseptal, you generally don't get chemosis. Proptosis, for those of you who don't know, is a bulging of the eye. So in orbital cellulitis, you tend to get proptosis because of its effect on the adipose posterior to the eye. Whereas in preseptal, because it hasn't gone into that orbit, no proptosis. Okay. Orbital cellulitis generally needs a CT scan because you need to see how far this is extending. And you must remember, you're not very far away from the brain. So orbital cellulitis does have the possibility of intracranial spread. It's a serious condition. And even if it doesn't spread there, just the fact that it's in that orbit and the amount of toxicity that this patient is undergoing, you need to be scared. You need to get this patient on antibiotics as quickly as possible. You need to get this patient as calm and as comfortable as possible. Most patients will present quite early because it is an extremely painful condition. However, we know that in our country, we do have a lot of patients who prefer to rather have traditional medication, and it doesn't matter race, religion, creed. We have this across all of our religious groups, all of our racial groups. We find that a lot of people, because they're scared of our hospitals, they tend to seek alternative methods before they come to us. So we get a lot of patients that present quite late to us. So you should expect that these patients will be quite sick by the time they get to you. Preseptal cellulitis generally doesn't need a CT, but if it is severe, it can be difficult to differentiate because you may not be able to elicit all the negatives here. So sometimes they do need a CT, but in orbital cellulitis, try and get a CT as quickly as possible. The most important thing that you need to remember, if you're working in an area without an ophthalmologist where you need to refer, if you're in an hospital with an ophthalmologist who just doesn't want to see a patient, which often happens, you need to speak their language. So you need to be able to tell them how the patient is toxic. You need to talk about the pain, the visual acuity. Even if you can't give them an exact visual acuity, even if you can mention the decreases, that's great. Pupils that are not reacting, chemosis, proptosis, these are things that you need to be able to do. And ideally get the CT scan from your emergency department, if possible, before it goes to the ophthalmologist, because that will actually help them determine what's going to happen later on. Not everybody has that in their institutions. Even if you are referring, try and make arrangements for the CT scan even before the ophthalmologist sees the patient. Okay, so that takes quite some time. Now, this is one that we actually had, and some of our doctors from Danhauser recently sent a patient like this through. The reason why I include this, even though it's technically not their eye, if we have a look at this is called a Pott's puffy tumor. All right, this nice big swelling that we've got over there. All right, it's a complication. They say rare, but we see them quite often. Complication of sinusitis. So the thing is, it's actually an osteomyelitis of that frontal bone that results in this nice big abscess that comes up over here. The problem is that it can extend to the periorbital area. So it can often mimic an orbital or preseptal cellulitis. Okay. The problem with the Pott's puffy tumor is that, or let's just say the differentiating factor is this forehead. So in orbital and and preseptal cellulitis, you generally have everything confined to this area, sometimes a bit up. But with the Pott's puffy tumor, it tends to spread into the forehead itself. And we had one guy, I think it was last week, like I say, one of our doctors, I hope she doesn't mind if I mention her name, Dr. Zondi from Danhauser, actually sent us a patient where there was orbital involvement, but you could see the spread right across there. I don't think I've still got the picture on here, but maybe I can put it up later on the group. But, it's an important differentiation to make. The problem with Pott's puffy is that it's quite prone to intracranial spread, very, very prone because of the osteomyelitis that's underlying here. And that osteomyelitis is quick spreading, extremely quick spreading. So these patients, I mean, this patient, you can see how ill she is. There's no luster in the eyes. You can see how down she is because she is toxic at the moment. And a lot of our patients we get with quite extensive spread, and they're at high risk for, cavernous sinus thrombosis, intracranial emboli, septic emboli. Oh, there's so much that can happen from a Pott's puffy tumor. So once you see this, what do? You in your emergency department make the diagnosis, arrange the CT scan, refer to ENT, not to ophthalmology, because ENT is not going to do much with this. ENT will then liaise with MaxFac. They decide between themselves who's taking it, depending, and even neurosurgery, if necessary, to actually decide how far to take this. All right, good. Okay. So this is a Potts puffy tumor with orbital involvement. Okay, so you can see how closely it can mimic it, but the truth is that it's spreading right up here. So it's involving this entire section. So that's the differentiating factor. Now, if you call an ophthalmologist and you tell them you've got an orbital cellulitis, they will often make the differentiation for a Potts puffy tumor because it can be difficult sometimes. This is an extreme example where it's really spread there, but it's actually involving a lot of the forehead. So that's why we call it a Potts puffy tumor. If you're unsure, for example, in one like this, you would rather get the ophthalmologist involved. And if you have an ENT on staff, call them as well and ask them to decide between themselves. The easiest way to differentiate it, CT scan. CT scan will tell you exactly what's happening in the sinuses, what's happening with the frontal bone, and whether the orbit is really involved or not. Okay. All right. So just some things that we sometimes see in the emergency department, although it's generally more common at primary healthcare centers, but we've got an external hordeolum or a sty and an internal hordeolum, which is an internal sty. So these are just acute blockages along this hairline, right, which can occur internally or externally, and it leads to this little painful abscess. Now, most of them don't need much. They just need a bit of hot compresses, some antibiotics, antibiotic eye ointments, whatever you have on hand. If it's really severe, then you transfer to an ophthalmologist, but even they don't do much with these. They advise more on compressions and things like that. And this is a chalazion, right? So a chalazion is also similar. It's also a a more of a chronic infection that happens across the eyelid. But it tends to have a more protracted history. It tends to be painless. There's not much that they do unless it's starting to affect eyelid function. They may remove it. Hordeolums, however, are a bit more acute and a bit more painful. But again, it's just for you to know the language between the two. Because if you tell an ophthalmologist to send a chalazion, they're not really too worried about it. But if say you're sending a hordeolum that appears to be quite bad, they may be a bit more open to it. But the majority of them respond to outpatient treatment. It's very rare that they do complicate, but it can happen on occasion. So this what I wanted to show you is just the types of conjunctivitis that we get, right? So there's quite a few: bacterial, viral, keratoconjunctivitis, allergic conjunctivitis. So the thing is, it's nice to learn the differences between them. So viral conjunctivitis is what we all remember as pink eye, that we all gave to one another in school. It tends to be bilateral, or it starts in one eye and then goes to the other. Well, all of them can, but this one is the more common one to actually do that. Generally very itchy, very painful. They tend to have a bit of blepharospasm, things like that. But it's a self-limiting illness that just requires analgesia. Bacterial conjunctivitis, as you can see, it's more of a purulent type of discharge. Also can start in one eye, then move to the other one. Generally associated with more pain than a viral conjunctivitis, and can also lead to ulcerations of the cornea and things like that. So generally, these patients also need to be covered with antibiotics, but most of them resolve quite quickly. Antibiotic ointments, systemic antibiotics, analgesia, anti-inflammatories, and they tend to settle down. You also can give antihistamines if there's a lot of itching in the eye, but not always necessary. Keratoconjunctivitis, as you can see, can be quite severe. Right? It's also a type of allergic conjunctivitis. But the problem is that this keratinization that takes place on the underneath of the eyelid. So if you look at this patient's eye nicely, you can see how that's actually affected the cornea and the iris. And it can lead to quite severe ulcerations. It can lead to quite severe abrasions. So if you see this, just be careful. Keratoconjunctivitis is one of those, conditions that needs to be seen by an ophthalmologist relatively quickly. How would you treat this patient? Depending on the severity, also if you have access to anesthetic eye drops, antibiotic eye drops, these are things that need to be treated at the source. So it is a bit of a difficult one, but just so long as you know what it looks like, then it makes it easier for you to refer the patient. Allergic conjunctivitis, we all know, tends to be bilateral. It tends to be quite itchy. It can be painful. The one differentiating factor is this chemosis, the swelling of the sclera. So that's normally what differentiates it, along with the severe injection of the eye. So allergic conjunctivitis treated with antihistamine drops, antihistamine tablets, steroids if needed. All right, good. And then we have a look at herpes zoster. So herpes zoster shingles. Herpes zoster that's just affecting, that's not affecting the eye, will generally stop around the forehead. But once you get it on the tip of the nose, then you must know that the optic nerve is involved. The reason why I mention this, I've seen a lot of patients being sent home, even though they've got zoster lesions on the tip of the nose. What that's going to do is eventually kill off the eye. It's going to kill off that optic nerve. And these patients need high dose IV acyclovir, if possible, or at least high dose oral acyclovir. And they need to be watched in an ophthalmology unit because they can deteriorate quite quickly. The problem with eyes is they don't regrow. So you've only got one chance, especially if you spot something that's quite problematic. So just remember that if you have a zoster lesion that's now spreading, all right, and right to the tip of the nose, just remember that it's involving the optic nerve. So you need to get this patient to an ophthalmologist rather quickly. And this is herpes simplex. Herpes simplex generally will cause quite a bit of irritation in the eye. It tends to give these dendritic ulcers, which are very difficult to pick out with the naked eye. You can see the cystine and it's under a slit lamp, but your patient will complain of recurrent pain, irritation, blepharospasm, things like that. And no matter what you're giving them, it's just not settling down. So when they go to the ophthalmologist, then they get these little dendritic ulcers that they see underneath. And these dendritic ulcers can get quite severe, especially if they're not treated. So don't just discount it. Basically, what I'm saying is you need to actually send your patient to ophthalmologist more often than not. Okay, so this is just some interesting stuff that I wanted to show you guys that we can see sometimes on ultrasound. Now, ocular ultrasound is quite difficult in that you need a high frequency probe, which we often don't have, in our emergency departments. But if you are lucky enough to actually do it, these are just some that you can see. So this is called a retinal detachment that we see over there. And the way that we actually figure it out, the snake-like movement of the retina that's detached from the rest of the posterior compartment over there. Okay, and this is called a vitreous hemorrhage. All right, so vitreous hemorrhage, they call it this is called the washing machine sign, because as you can see, it looks like clothes moving in a washing machine. All right, so if you're ever lucky enough to get your hands on a high frequency probe, then it's lovely to have a look at these things, and it helps you to differentiate even before you get the patient to an ophthalmologist. But most of us don't have access to that, and I must be honest, with our curvilinear probes, you're not going to see this. You'll be very lucky if you can see that. Okay. So this is just a still image of a globe rupture where you can see the entire globe has just collapsed. There's nothing there. All right. And this is an intraocular foreign body. As you can see, it's casting those bright comet tails. So this is as the patient's moving their eye, and you can see the intraocular foreign body. And if you recall our previous lecture that we had, we talked about, the velocities and how things get into the eye and what it looks like. But that's just to show you what it looks like on the inside. Okay. All right. So this is how you have to actually do an ocular ultrasound. So you can see they do something called a gel bath. So there's a large amount of gel that's placed over there. And then you can see with the straight curvilinear probe, because the reason being we want to avoid excessive pressure on the globe. If you've got a globe rupture or a foreign body in the globe or even a vitreal hemorrhage, if you actually place too much of pressure, you can worsen the condition. So this is how it's done. So there's some lovely things that are done with these linear transducers. I'm hoping to get one eventually, but it's 140,000 rand. So I doubt very much they're going to give it to me in the emergency department, especially considering radiology is right next door. But it would be fun if we could. They tell you a lot, especially when you get towards hands, muscles, the way you can look at shoulders. Oh, it's amazing. But unfortunately, most of us won't have access to it. That's why I haven't spent too much of time on ocular ophthalmology. And in fact, we won't get into it. Ocular ophthalmology, ocular ultrasound. Okay, I think my drugs are kicking in. No, I'm just kidding. All right. So, super glue. Yeah. For some reason, your patient applies super glue to their eyes, and you can see Kevin Hart's reaction, WTF, but it does happen. Okay. So, what do you need to do when your patient has super glue? The main thing that you do is you apply large amounts of Chloromax ointment. All right. If you don't have Chloromax available, then use Vaseline. What you're trying to do is moisten up the super glue as much as possible. And then what you're trying to do is remove clumps that come loose, but don't try and remove everything. Once you do that, there may be attachment to the sclera, the cornea, the conjunctiva, and if you try and remove that, you're actually going to cause more damage. So what happens is your ophthalmologist then in theater attempts to remove the rest of it under microscopy, but this is what you can do in an emergency department. Large amounts of chloromax ointment, you put it in there, you rub it on that super glue, and you allow it to go. Now, this is by no means the only, there's a lot of studies that are going on about how to get super glue out, and I'm sure you guys saw the Gorilla Glue lady recently. I'm sure that somebody's going to try Gorilla Glue on their eyes as well. So I'm sure we'll find new ways of doing it, but these are two that have worked. So as you remove those clumps, your patient is able to open their eye. As they open their eye, they can eventually separate. But the most important thing is for you not to tug and try and remove as much as possible, because you'll actually damage your patient's eye more than anything else. Okay. All right, so what about acute glaucoma? So this is something that happens because it depends on especially close angle glaucoma, depends on the angle between the iris and the cornea. So what do your patient, and it's a nice thing if you want to go and read about the pathophys, I'm not going to get into that right now, but let's talk about what your patient presents with. So present with an acute painful vision loss or vision reduction. Frontal or orbital headaches, nausea and vomiting, very important, right? The pupil is fixed and non-responsive to light, which is one thing that we're going to talk about just now. And they have this hazy or edematous cornea. So you can see how you can't see clearly through it, like how you would, well, let's say, for example, even here you can see Kevin Hart's iris quite easily. Let's get another one. There, even here, you can see how easily you can see the iris and the pupil. And then when you come back to this, let's just get through Kevin again, you can see how hazy it becomes. And that's actually one of the first things. And the other thing is that the eyeball feels like a marble. So if you were to put your thumbs on each eye, you would notice the one that's affected actually feels quite hard, okay? But you've got to remember all of these signs, okay? And some of the more common ones, nausea and vomiting, the vision loss, the fixed non-responsive pupil, the hazy edematous cornea, and the increase in intraocular pressure. So these are the things that you need to look for. And these are things you can Google if you forget everything after I've spoken now. If you suspect your patient has it, just Google it. It just comes up as a quick list of how you do it. So dexamethasone and hydrocortisone IV are the two ways that you can treat it. It just brings down swelling. And of course, you've got to treat the symptoms related to pain and to the GIT. And at some point, you can use mannitol, but generally you're going to call a senior. I wouldn't advise you, I'm just giving it to you as an example, but I wouldn't advise that you use it. Even the ophthalmologists don't advise that you use it. In fact, a lot of them, what they do when I was speaking to them, is that they actually do an ocular massage, but most of them will ask you to admit the patient on high dose dexamethasone, hydrocortisone, analgesia, something for the nausea, something for the vomiting. And the thing is, you need to get some patients are using Midriatics and things like that. So that's where you have a problem. So they come in, they try and get this pupil down again. They try and relieve that pressure on the inside. And the most important thing from our point of view, because it's very unlikely we can sort out acute glaucoma in an emergency department setting, but we can at least try and reduce it a little bit. Mannitol, like I said, it's just to know that it is an option. But I must be honest, I wouldn't advise you use it all the time when you get an acute glaucoma. I would use it for somebody who's presenting with such significant pain and complete vision loss. And then even then you would do it under the direction of an ophthalmologist, because they need to know what this patient has been receiving. So how does the mannitol work? Osmotic diuretic causes intravascular collapse, basically, that reduces pressure within the eye after that. Okay, but it has a lot of other side effects. So that's the end of the presentation for now. I hope you guys enjoyed it. As I was saying last week, it's quite a boring topic actually. Personally, I don't like medical conditions of the eye. I find them to be something that's not nice to treat in the emergency department, because the majority of the time there's not much that we can actually do. The majority of the time we are sending them off to the ophthalmologist. But as you can see, there are little things that we can do to make sure at least that we send our patient to the right person, that the patient is treated correctly. And for certain emergencies, yeah, there are things that we can do. I mean, you think about the super glue, the acute glaucoma, your orbital cellulitis, there are things that we can do. But it's one of those, eye conditions are just some of those conditions where you really need a specialist to take over. because there are so many intricacies, and you really only have um, a few chances, to actually get it right. And if you get it wrong, you've kind of condemned that person to losing their eye. So, my view on ophthalmology and ophthalmology conditions, be it trauma or be it non-trauma, is get the ophthalmologist involved sooner rather than later. Ophthalmologists themselves are lovely people, very wonderful people, but they're not going to rush out and see every single patient. So you need to understand the condition that you are trying to express to them. You need to be able to tell them that this is what I'm seeing. This is why I need help. This is why I want to refer. The good part about ophthalmology is that most of the things can be seen within 24 hours. So it doesn't need an urgent referral now and now. But there are those few that do. So if you suspect that your patient does need an urgent referral, needs to be seen now and now, you need to speak the language of that ophthalmologist, which is something I tried to teach you over the last 2 lectures. And hopefully that will help you moving forward. Now, of course, we can't teach you ophthalmology in 45 minutes, but these are the common conditions. There are less common conditions, things where I must be honest, even I've looked at the patient and gone, geez, what the hell is going on here? And then you ask for help. Asking for help is not a sign of weakness. I always tell my guys as well, if a gynecologist doesn't know how to treat depression, that's not a bad gynecologist. And if a psychiatrist doesn't know how to deal with an ectopic pregnancy, that's not a bad psychiatrist. We all need to know our place. And our place in the emergency department, stabilize the patient, try and make a good differential, and eventually get the patient to the right person if we can't sort it out. So that's what you need to be able to do at our emergency department level. So I hope you guys enjoyed that. And yeah, hopefully we will have a talk on ear injuries and ear trauma and ear emergencies the next time. Okay, thanks everybody.